Right, so that's my brief. I must admit I wasn't too sure what it meant until just recently, but I think I've got it knocked into some sort of a shape. This word, I gather you've seen before, is that right? I don't actually know what it means. Is it just from one?
It's a whole year's worth.
A whole year's worth, is it? Okay.
So a whole year's worth of clinical science.
And it's all the things that the people found difficult, is that right?
It's everything that the candidates got right less than 40% of the time, which, given that the average chimpanzee gets it right 20% of the time, shows that it's fairly difficult.
Right, so that sort of explains, and then what the point this slide is really making is, if you read those things, at least sort of 5 of all of that lot is to do with haematology. So if you can learn your sort of haematology basic science well, then you get a lot of bangs for your buck, basically. And it turns out there's a lady who was very central to setting sort of exams in the College of Paediatrics. What's her name?
Mary Rossiter.
Who really, really liked haematology, and therefore got a lot of questions in there. And I think there's a sort of hangover of it being a high proportion of the theory test. So there's lots of worthwhile things to pick up from there, really. The other thing is, you know, if you're doing OSCEs, just occasionally people will tease you by sort of saying, you know, can you do an appropriate examination for this patient who's got a reticular endothelial problem? And then you've got to sort of suddenly work out what you're going to examine. So it is, you know, another area to think about, not just in your MCQ questions. Right, so this is the sort of thing that we're going to go through. I'm going to try and give you a strategy for the interpretation of a full blood count. That's basically going to be teaching you to suck eggs. I know you know perfectly well how to do that, but it's sometimes quite a good idea to just do absolute basics first. And then we're going to look through blood cells and haemoglobin and thinking about the pathologies as we go along. So, just in sort of broad details, and anybody's been taught in Kiel. I don't think anybody come through Kiel Medical School. No, so nobody's got a sort of one up on knowing what my little bugbears are. Well, if you're going to approach any data question, there's a basic strategy for any data question, whether it's an X-ray, a CTG from an obstetrician, a laboratory blood test. What's your basic way of approaching any data? Any ideas? Excellent. Perfect answer. So identity first, yeah? So I would always say that it's identity first, because then you're not making decisions about the wrong patient. Quality second. You know, how many, I don't know if you've been called to deliveries yet, you know, and they're really worried about the fetal bradycardia, and they find their probe lying in the bed about 2 foot from the mother. It's very common, at least it was when I was a junior doctor. So quality of data really, really matters. And then finally, you need to have some sort of strategy for interpretation. So if you're going to interpret a full blood count, what are the 4, if I was to allow you to have 4 parameters, which are the 4 that you'd want to interpret a full blood count? Haemoglobin, yeah. White cell count, platelets, and what's that? The 4th one. You see, from my point of view, I really hate having somebody telling me full blood count results and not having this 4th thing. MCV. You must have MCV, otherwise and it's amazing how many patients on the ward now. I bet I could go around the wards now and find patients with MCVs of 63 and 65 who need to go home on iron, and nobody will bother to even look. So those are the sort of the 4 parameters you must have, okay? So haemoglobin can obviously go up and down, can't it? And these are the pathologies that might sort of cause it to go down. Clearly hemorrhage, nutrition, so we're thinking about iron, B12 and folate, aren't we? And then something else that I stuck in there after sort of a bit of thought is anything that stops you producing DNA. So that's why folate and B12 are important. And it's also why this theory of science course is so important, because there was a child 2 years ago who was very, very sick on the wards with distended abdomen, diarrhea, failure to thrive, and pancytopenia, and no immunoglobulins. So we thought, oh wow, this must be some sort of weird immunodeficiency, and ended up trying to keep the child alive for a few days and then sending them to Newcastle, the regional immunodeficiency centre. The child was there for a number of weeks and eventually died. But what this child had, if you think about it, with pancytopenia and inability to produce the lining cells for the gut, was a problem of making DNA. So this was a child with, it's just got out of my brain now, transcabalin deficiency. That's something that helps you use B12 to make DNA. And I gather, do you remember there was a Russian who got poisoned with plutonium? It took doctors quite a long time, a week or so, to work out what was wrong with him. And of course, it's exactly the same thing. He was radiation was meaning that he couldn't make cells, and it's basic science that gets you there, you know. Whereas actually, this took a year for somebody eventually to screen this child's blood and discover the genetic abnormality, a year after they died. And you know, we could have picked it up if we'd really thought what the things were. So just something to think about. Low hemoglobin, chronic disease. That I don't think anybody knows how that works. Does anybody know why chronic disease?
No, and I tried to look up.
Yeah.
Cause of macrocytosis. Stephen was preparing this.
Yes.
I think we're going to come on to that.
Yeah.
DNA versus hemoglobin.
Yeah, but chronic disease I never really got to understand. And then renal disease, obviously, because erythropoietin is the hormone that leads you to produce hemoglobin, and so if you've got kidney disease, you can get low erythropoietin, low hemoglobin. And then high hemoglobins are from hypoxia, fetal transfusion between each other can leave very high hemoglobins at birth. And I think you can get excess erythropoietin from renal tumours, can't you? I seem to remember that from somewhere, but I couldn't find a reference. So white cell counts, the sort of processes there are going to be infection. So as you know, bacterial, neutrophils, viral, lymphocytes, parasitic eosinophils, obviously leukemias, and again this baby we had a low white cell count. And then platelets, you can get very low platelets with ITP and an autoimmune platelet destruction disorder. Again, low platelets with septicemia, where there's coagulation within many blood vessels consuming platelets. Again, leukemia if you're not producing platelets. You can get high platelets in inflammation, so prolonged high platelets can be a bit of a worry. It means there's some sort of connective tissue causing high inflammation all the time. High platelets in bleeding, and then there's some various platelets disorder, Glanzmann and things like that might give sort of smaller numbers of platelets. And then microcytosis. What are the 4 causes of microcytosis? You must know that. Brilliant, and that's the first and most important one. Well done. Thalassemia, that's the second and most important. Lead poisoning, yes, and then the 4th one's a weird one. Sideroblastic anemia. I always remember that from my membership because there's only 4, so it's fairly easy. The others, there's so many on the list that it gets a bit impossible to remember, but microcytosis is easy. And then macrocytosis, you know, B12 folate problems is making DNA. So basically you can make the red stuff, but you can't make the cells. So the cells have to end up big. Reticulocytosis is because young red blood cells, which are called reticulocytes, are bigger than normal mature red cells, and so you'll get a higher volume with those. Anything where you've got a problem making DNA, so sort of rare metabolic disorders like my child with transcarbamylin deficiency. I'm not quite sure why liver problems cause. I know that if I drink too much alcohol, that would increase my MCV, but I don't know why. Do you know? Yeah, so the iron, you make the hemoglobin, but you can't make the cells. Same sort of basic idea. And I'm sure hypothyroid works in the same way. So I think all that's teaching you to suck eggs, nothing new, I'm sure, but just important to think about it, really. One of Will's slides about microcytic anemia. I think really chronic disease is sort of normocytic, but sometimes a bit reduced. Iron deficiency, you're going to get the hemoglobin will all depend on exactly how much iron deficiency you have. The MCV in iron deficiency, in my experience, is normally in the 60s, obviously, or 70s. So an MCV of 62 and a hemoglobin of 9 would be sort of typical. They'll have reduced iron, increased total iron binding capacity, I don't think I've ever measured. Whoops, page up. Transferrin receptors, but iron saturation is clearly going to be reduced. With anemia chronic disease, all of those things are normal or slightly reduced. With thalassemias, they're obviously different from iron deficiency most of the time because the MCV is in the 50s. Okay, so if you see MCV in the 50s, it's unlikely to be iron. I think it could be if it's very severe, but much less likely. In terms of just sheer practicality, if you do see a low MCV and hemoglobin around about 80 to 100, then you need to give them a course of iron and then send off the electrophoresis, and because they can't pick up the thalassemias very well if there's any hint of a iron deficiency. So you really need to have a normal ferritin before you start doing hemoglobin electrophoresis for thalassemia. Right. This slide is really just for me because I was trying to put things in an order. It took me a while to work out how to do it. So I'm basically going to talk about red blood cells, their structure, their physiology, their production and their destruction. And then we thought we'd do exactly the same for hemoglobin. Its structure, physiology, production and destruction. So it's just basically giving you a guide of where we're going. Right, some cool facts about red blood cells that Will found out for me. You all know that they live 120 days, 3 months. That's something you learn really on in medical school, isn't it? Neonates, they don't survive quite so far. I didn't know this one. I think this is ace. Apparently they travel about 300 miles in that time. I think that's really cool. There's this stuff called 2,3-diphosphogluconate, which
shifts the oxygen dissociation curve
to the left.
Makes it better at holding on, so getting the oxygen, not so good at giving it. Remember when I said yesterday?
Oh, actually, no, it shifts it to the right, doesn't it? So that it gets them to release oxygen. Yeah, that's right.
No, that shifts it to the right. You're quite right. CO2 and 2,3-D produces to the right.
Yeah.
So fetal hemoglobin is really good at binding it, but not so good at giving it up. But then if you've got 2,3-DPG, it makes it better at giving up.
Yep. And the really important aspect about that is that means that fetal hemoglobin can take oxygen off the mother's hemoglobin. Yeah. So that means that it doesn't have the response to 2,3-DPG that it should have, so that it means that fetal hemoglobin, I'll show you on, it's going to be much easier when we actually look at the oxygen dissociation curve. We've got a slide for that later, but you'll be able to see that fetal hemoglobin tends to hold on to oxygen more tightly. So it'll take it from the mother's placenta quite nicely, and then in the fetus, they tend to work at a much more hypoxic level, as you can imagine, and so it does release the oxygen eventually to the fetal tissues, but at a lower oxygen tension. And it turns out that most of your iron is actually in red cells, as opposed to bound to transferrin, waiting and stored. Right, so red blood cells. Everybody knows that they're sort of 8 micron and a biconcave shape. People have always said that the biconcave shape is because it increases diffusion across the of oxygen and CO2 across the cell membrane. But actually, they're beginning to think that it might be more due to enhancing laminar flow in blood vessels. and they've shown that where people have spherocytites, they are actually more prone to strokes and coronary artery disease after splenectomy. So actually they're roughly equivalent to people who've had a splenectomy but haven't got spherocytes. When they're first produced, they have some more reticular endothelial elements to them that allow them to respire using the oxidative phosphorus system. But by the time they've become mature red blood cells, then they're very much only going to be able to use glycolysis to produce their energy. Obviously, red cells are where you make haemoglobin. Heme, funny enough, isn't only made in red cells. Heme is also made in your liver, and then that's used in things like cytochromes. So you know in disorders like porphyria that you get liver disease and neurological disease with heme disorders, and that's because heme is not just a red cell thing, it's also a sort of liver thing. So I think that was most of what I wanted to say on that one. Yeah. Red cells, as you know, have a sort of leaflet of phosphates around the surface with your sort of hydrophobic ends on the inside and your hydrophilic ends on the outside. And then there's a number of sort of key proteins that coordinate the sort of structure of the red cell that are attached to that. There's these sort of vertical ones. Can you see these vertical ones here? I think it's the vertical ones that are particularly related to spherocytosis. If those are abnormal proteins not working properly, then it doesn't give the structure to the red cell that it should have. So instead of making that biconcave shape, they become round, and also they're much more prone to damage as they go through narrow capillaries. So you know I was saying they're 8 microns in diameter. When they're going through the spleen, they're actually having to go through gaps around 3 microns in diameter, so they're sort of squeezing through quite narrow parts. And the red cell skeleton has to be able to cope with that deformation and movement. And if you've got a disorder like hereditary spherocytosis, then that's because these vertical proteins aren't working properly. Meanwhile, if you've got horizontal proteins not working properly, then that tends to cause something called elliptocytosis, just another one of these abnormal cell things. Because you've got these problems in spherocytosis, they're much more prone to hemolysis, and the red cells don't last as long. So I think those are the main things. Was there anything you particularly wanted to get out of that?
I'd say, well, often about 60 to 70 days in hereditary spherocytosis, which becomes important when you have things like parvovirus, because that causes that pause in red cell production, and often that pause will be for about 60 days. So if you've not got hereditary spherocytosis, you become anemic, but you just go a bit pale and you get through it. But if you've got a red cell survival time of 60 to 70 days and you stop producing red cells for 60 to 70 days, you become very, very ill. And that's why that's a more serious condition in someone with reduced red cell survival. And that's sometimes how children present.
So the structure of the red cell does depend on the red cell being able to produce energy and maintain those proteins. So that comes back to glycolysis, or the Embden-Meyerhof pathway, if you prefer it. Do you remember this from medical school? You know, glucose turning to glucose 6-phosphate, and then glucose 6-phosphate dehydrogenase turning it to fructose 6-phosphate dehydrogenase and reducing NADP, which is a very useful energy exchange protein in the body, isn't it? And then the use of glutathione to really maintain the structure of the proteins of the red cell. I had to change this slide, Will, because in the one before it got pyruvate kinase in the wrong place.
Oh, well, I can't remember where I took it from.
Yeah, but it's real. It's kosher. I found it too, but it was wrong. So pyruvate kinase, what's the right word? catalyzes the or enzymatically advances the conversion of phosphorenol, I forgot what it is now, into pyruvate. And so it was, they put it down here, it was the wrong place. So the key message is that you need red cells to survive. There's in fact, the most common genetic enzymatic condition is glucose 6-phosphate dehydrogenase. Apparently it affects 400 million people across the world. There are more than 300 different variant abnormalities of the enzyme that produce the enzyme glucose 6-phosphate dehydrogenase. And I guess the reason it's such a common abnormality is that it does give you some resistance, partial protection against malaria. So that's going to be in parts of the world, where malaria is a problem. So Africa, Asia, some parts of the Mediterranean. So we need to think about that for children who present with jaundice or hemolytic anemia, who come from those areas, really. So I think that's the most thing for that. Yeah. The classic causes of hemolysis, obviously I did talk about sort of newborn babies get jaundice, but these people are prone to hemolytic anemia from, the classic one is favism, do you remember that from fava beans? But also there's different medicines and things. What are the medicines?
Does anyone know what we call fava beans in the UK?
Oh yeah, that's a good one.
We call them broad beans. So if you know that broad beans are fava beans, now the Silence of the Lambs makes a lot more sense to me. So a nice Chianti liver and some fava beans. Well, they're just what I never knew what fava beans were all the way through medical school, and so it was a relatively recent surprise to me that fava beans were what I call broad beans. And so you find them in paella, for instance, and lots of other dishes. So we do come across them a lot. I thought, well, I've never eaten fava beans, so why is that important? Well, I've eaten lots of broad beans. For the UK
Me too. So it's antibiotics and medicines for malaria that are likely to trigger a problem for those. Okay. Glucose 6b deficiency is affecting a gene on the X chromosome. I should say it's the distal end of the long arm of the X chromosome, and so it means that it's an X-linked recessive disorder, so it's going to affect boys. Whereas pyruvate kinase deficiency, which has a similar sort of effect, to be honest, is an autosomal recessive disorder. But I think these children have hemolysis very much more through their life, and so they end up with persistent reticulocytosis, growth failure, failure to thrive, problems with cholelithiasis, and they also have a lot of extramedullary hematopoiesis. So pyruvate kinase, I think, tends to be quite a bit worse, where they're always working very hard to produce red cells the whole time.
And the retics in those conditions are often 8 to 12% when it comes to exam questions. They're kind of in that range.
So what's the normal retic count?
1 to 2%.
Yeah.
So normal predicted 1 to 2. So always look at the reticular side. So if you're seeing sort of significant extramedullary hematopoiesis, you're seeing retic counts up in that 8 to 12 range.
Brilliant. And a good clue to it in haematology, if you look at the film, are Heinz bodies. So with this haemoglobin getting, what's the right words, oxidized, the haemoglobin forms little things that you can actually see on a film, these Heinz bodies of denatured haemoglobin.
And as we all know, there's 57 varieties. You don't need to know that for the exam.
I haven't the least idea which 57 there are. Breakdown of red cells. You get, we all know they last 120 days, so that means there's roughly 1% a day being broken down. Your liver produces a protein called haptoglobin, which is actually acute phase protein. So if you're ill, the amount of haptoglobin is meant to go up. Okay, but haptoglobin's job is to bind onto hemoglobin if that's been released into the blood, and when red cells are broken down in the spleen or the liver, the hemoglobin gets released into the blood and haptoglobin binds it. You can work out from that, if you've got hemolysis, that the haptoglobin will all be used up, because once haptoglobin is attached to hemoglobin, it gets mopped up very, very quickly by the liver and absorbed. So in hemolysis you end up with a low haptoglobin level. There's something else I was going to say about that. Yeah, it's the reason why haptoglobin is so important. One of the reasons is that haptoglobin stops hemoglobin damaging the kidneys. If you get raw hemoglobin going through the kidneys, you get hemosiderin formation and damage, and that rings a bell with myoglobinuria, which is a similar disorder, basically. So haptoglobin prevents that renal damage that you would get if you had hemolysis. One of the things I did find out that was quite interesting, I thought, when you look at the spleen, apparently it is really quite an unpleasant environment for red cells, the spleen. It's hypoxic, which means that they can't use the little bit of oxidative phosphorylation capacity that they do have in their ribosomes, reticular. Anyway, they don't have mitochondria, red cells, but they do have some areas where you can do a little bit of oxidative phosphorylation. So when they're in the spleen, which is very hypoxic, they can't do that, which puts them under more oxidative stress. Also the spleen is a nasty environment because it has very, very narrow passages for the cells to squeeze through. So it really is designed to pick up old red cells, rupture them and get rid of them. That's what your spleen does, or one of your actions of your spleen, clearly. Hemoglobin, when it breaks up, obviously releases heme, and the iron bit of that gets put into ferritin to make transferrin, and is used by transferrin to be transmitted to the liver and stored with ferritin. The globin part of it, the protein bit of heme, is it's a circle of 4 pyrrole elements that gets cut, so it's a straight line of 4 pyrrole elements. That's biliverdin, and that very quickly gets turned into bilirubin. And then bilirubin is carried by albumin through to the liver. In the liver there's ligandin, isn't it, that grabs hold of your bilirubin, and you get transfer of the bilirubin into the liver cell, where you get UDP, uridyl diphosphate, you get glucuronidation of the bilirubin, so then you get conjugated bilirubin, which is excreted in the bile. Once the conjugated bilirubin gets excreted in the bile, it then goes into your gut, where the bacteria can produce urobilinogen, which is something that is water soluble and ends up going back in through the gut wall and back into the bloodstream and out in your urine. And also the bacterial action on bilirubin is to convert it into stercobilin, which is a sort of brown pigment which makes your poo brown and obviously comes out bottom end. So that's broadly what happens to hemoglobin at the end of its life. And yeah, that's shown on this slide quite nicely.
And knowing what makes your poo brown is like a fundamental question to working out everything in that pathway. If you can explain to a 10-year-old what makes your poo brown, you understand it. And it's the sort of question your average 10-year-old quite likes explaining.
Or at least they're amazed if they find somebody who is prepared to. Yes. Right, so this is an example question which I thought was quite interesting. Which of the following is most likely to be found in a child with mild hereditary spherocytosis? Okay, so What do you think? High haptoglobin. So what's going to happen in mild hereditary spherocytosis? So this is a disorder of the red cell cytoskeleton we were talking about earlier, those vertebral elements in the cell membrane. And so that means that the cells get damaged more easily, so they don't last as long. What do we decide, about 80, 90 days? Unless there's something nasty going on, it's not too bad. It's quite mild, as just cells aren't lasting as long. What do you think about the haptoglobin? What should happen with that? So what does haptoglobin do? Do you remember? So haptoglobin binds hemoglobin. It's produced at a sort of steady rate by your liver and will go up if there's inflammation. If there was a bad episode of hemolysis, haptoglobin would go down. Okay, but in a steady state, it'll be a sort of even amount. So somebody with a severe dose of hemolysis, you'll get low haptoglobin. The only time you'll get a high haptoglobin is when you're ill, because it's an acute phase protein. Okay. High cholesterol, I think that one is in there entirely as a, what's the right word for it? Distractor, that's right, I knew it was a good word for it. Does anybody know of any link between cholesterol and hemolysis and stuff? I can't think of one. No, I think that's there. Now this one is one where you have to think very carefully. Hemoglobin A1C, what is it? Brilliant, yeah. So that's where you've got glycosylated hemoglobin, what affects how much glycosylated hemoglobin you've got? Yeah, so it's sort of how high the average sugar level in your blood, isn't it? Because over that 120 days, gradually your hemoglobin going from pure virgin hemoglobin gets more and more glucose added to it. If you've got red cells that last less time, what do you think? I'm getting a few nods for that one. So that looks, possible. I mean, it's not something I know anything about, but just on first principles, you can kind of half work out that, it might go down, mightn't it? Okay. And then low platelet count. So what's the link between hereditary cystosis and low platelet counts? We talked about low platelet counts before, didn't we? So that's sort of coagulopathy. Don't really think they have coagulopathy, do they? Patients with hereditary spherocytosis. There's no autoimmune aspect to it. Although they're sort of vaguely to do with blood, I think it's there as a distractor. Is that right, Will?
It is. Well, if you get a large spleen...
Oh yes, I forgot about splenectomy.
So the reason it's mild hereditary spherocytosis rather than severe is that with time and with age you often get increased spleen size, which then turns you from mild to moderate to severe hereditary spherocytosis when you're looking after them. So you find as their spleen enlarges, they get nearer to needing their spleen taken out. And they may start to get low platelet counts near the end. So that's a real test, and it's not absolutely a distractor. It's got some knowledge in it that I wanted to bring out. Don't worry, keep on.
Cool. And low serum bilirubin. Which way do you think the bilirubin would go if you had a hemolytic process up? So that's obviously naff, isn't it?
And it tends to be somewhere like 40 to 50 for the milds, but that's not how you categorize mild, moderate, and severe. You do it on the basis of their hemoglobin, but it's definitely wrong. It's definitely wrong.
So we're left with thinking that this rather interesting one here might be right. So let's see what Will says. So haptoglobin should go down in hemolysis. That one's there as a distractor. This one's sort of blanked. That one's interesting, isn't it? In this splenomegaly, yeah, and that's definitely going the wrong way, so it's not that one. So the answer is hemoglobin A1C. So you sometimes have to work these things out from first principles, really. There was nothing I read that gave me that was low.
So there is an important... If you ask a diabetologist, they know that you can't rely on HbA1c in children with hemolytic diseases or hemoglobinopathies with reduced red cell survival. So the HbA1c is falsely low. They all know that, but they're not taught you. But you can work it out from first principles. So it's a really good theory and science question, isn't it? Yeah. So when the hemoglobin, when the red cell gets broken down, as Steve says, the heme molecule gets broken down again, and the glycosylation is removed. And the amount of glycosylation is directly proportional to the serum glucose over the period of time that the red cell survived. So if it survives for less time, HbA1c is falsely low. And so it's a very sweet bit of science that the question tests understanding. This is what we're trying to get the questions to. And if you understand, you can work out all of those from first principles.
So should you always think of hemoglobin that's all worked out with
Well, it depends. If you've known your patient for 10 years, you're pretty hopeful that they haven't got hereditary spherocytosis, yeah? But I suppose if you're relying on HbA1c, the condition in particular where that is important is that a lot of CF patients, because they've got increased red cell turnover as well, when they start to get CF-related diabetes, HbA1c becomes an unreliable marker of CF-related diabetes, and the reason is reduced red cell survival. So Andy's a respiratory pediatrician as well, that's why I'm looking up behind me. So we kind of know that in CF, HbA1c is no good, so we're doing continuous glucose monitoring to diagnose CF-related diabetes because we can't really rely on HbA1c. So there's lots of times where it's not reliable, but anything that reduces red cell survival will make it not reliable.
I found out another useful thing about HbA1c, useful, interesting anyway, thing about in my reading, and that was that it's usually in a lab done by electrophoresis, and some hemoglobinopathies move at in the same band as it. So if you've got an abnormal hemoglobin, it can move with HbA1c, and so you get false readings with that. So do you remember I was saying about any data you should look at ID? The next thing is quality. So you have to hope your lab's up to it to make sure they can differentiate the two. Right, so moving on to red cell production. Let me get something I'm meant to be saying about this. So hematopoiesis. So we talked a bit about this is still carrying on with the idea of talking about red cells, let's make sure we've got the right place. Yeah, hematopoiesis is quite a complicated disorder, a process really. The hematopoietic stem cells exist all the way through your life. Okay, so as an adult you do have these. There are about 1 in 2 million of the progenitor cells in your bone marrow. You're not going to spot them because they just look like a normal lymphocyte. They are undifferentiated, so they're going to be very difficult to spot. 1 in 2 million and looking normal. You can use immune probes to find them. So they're CD34 plus and CD38 minus, so you can work out which ones they are. And they have this amazing ability to not just produce one of themselves, but produce one of these progenitor cells. And then these progenitor cells can either be in the myeloid series or the lymphoid series. And then if you've got one from the lymphoid series, then that will further divide and produce colonies of T cells, B cells, and killing cells, natural killing cells. Similarly, the myeloid progenitor will produce progenitors of the megakaryocyte side or the granulocyte macrophage side. And it's the megakaryocyte erythroid progenitor that then goes on to project your red cells and your platelets. Whereas the granulocyte macrocyte size goes on to produce all your different sorts of granulocyte white cells, so neutrophils, monocytes, eosinophils, and basophils. This is all under the control of a whole load of factors which interact to produce the bits that you need. So the final sort of thing is erythropoietin for red cells, and there's a similar thrombopoietin for platelets. There's a granulocyte stimulating factor for neutrophils and monocytes, just as there's other things for basophils. So we can use synthetic hormones to try and encourage the production of the individual elements that we want. Where was I going to talk about it? Maybe I'll talk about it now. I'm probably talking about it in the wrong place. No, I think I'm going to talk about it later. Sorry about this. Make sure before the end that I tell you sort of at what stage of the embryo and fetus and adult these things are produced. But I think, that is what I need. Right. So now I'm going to move on to haemoglobin. We've talked about red cells and their structure, physiology, production and destruction. So now I'm going to go on to haemoglobin. Do you remember doing this in biochemistry in year 1 in preclinical medicine? You'll know that haemoglobin is made up of 4 different globin molecules, usually 2 alpha and 2 beta ones, that each of those globin molecules surrounds a heme element, the heme element having the iron bit in the middle. Heme is made from it's manufactured by a process of do you remember no, I'm not going to go into that. That was quite complicated, so I'm not going to go into it. So you end up with 4 pyrrole elements surrounding the iron molecule. Do you remember that the haemoglobin A, so in this one that's the green, isn't it? That's made up of 141 amino acids, and it's coded for on chromosome 16, whereas the beta chains are coded for on chromosome 11, and they're all synthesized in the cytosol of the red blood cell. That's the main structure. You'll know also, and we'll come on to it later, that there are other globin chains, so that there's the gamma chains, which make up alpha-2, gamma-2 with the haemoglobin F that you find in fetus, and there's other ones, the delta, epsilon and zeta ones, which will come along later. This is that oxygen hemoglobin oxidation dissociation curve that we were talking about earlier, and its shape depends on the structure of hemoglobin. So each molecule of hemoglobin binds 4 molecules of oxygen, and when a molecule of hemoglobin first binds oxygen, it increases its avidity to the second molecule of oxygen. In fact, as each one binds, it increases the affinity of hemoglobin to the next form of oxygen. Now, normally in our bodies, we're working between 75 and 100% saturated with oxygen, and that is literally, as you might expect, between 3 and 4 molecules of oxygen per molecule of hemoglobin. The important points that this is making is that you can see that as if you're at a low partial pressure of oxygen, then you've not got much oxygen in your hemoglobin, and that's when you're at high oxygen tensions, you've got a lot of oxygen in your so you've got fully saturated hemoglobin. Once you're carrying your 4 molecules of oxygen, you can't carry any more, so you've reached a saturatable system. I suppose delivery of oxygen to the tissues all depends on allowing the blood to get to a place where oxygen is released. And the things that help oxygen being released are the fact that the tissues have a lower pH, because that moves this dissociation curve to the right. So anything that moves this curve this way is going to increase the ability to release oxygen to the tissues, whereas anything that moves the curve that way will increase the avidity of haemoglobin for oxygen, and so I suppose will increase the haemoglobin's ability to grab oxygen from, very usefully, mum's placenta if you're a fetus. Okay, and it's useful from the oxygen carrying point of view if when you get into the tissues that it can release it, and so that's why you want things like a lower pH, pH 7.3, and I don't think you normally get a higher temperature in the tissues, but that would help release oxygen, and a raised 2,3 dpg, as we were talking about earlier, will also allow oxygen to be released in the tissues. It's interesting that in anemia you get raised levels of 2,3 dpg, and the other place that you get raised levels of 2,3 dpg, as I'm sure you remember, is in high altitude acclimatization, which makes you produce more of that chemical. On the other hand, you get situations where you get low 2,3 dpg, and the most common situation for that is going to be transfused blood. So unfortunately, blood, when it's stored in a bag over about 14 days, more or less loses all of its 2,3 dpg, and that means that it takes about 24 hours for that blood to regenerate the levels of 2,3 dpg that would give it a normal oxygen dissociation curve. I suppose that's why anaesthetists like patients to be transfused 24 hours before theatre if they possibly can. Obviously, even though it's got very low 2,3 dpg, it does do some jobs. So, in extremis, of course, it is worth transfusing a patient. It will give them some help from that moment. There are other things that affect the how much oxygen is going to be carried in haemoglobin, and I suppose one of the most important would be other ligands like carbon monoxide. Unfortunately, carbon monoxide has a sort of 300 times the affinity for haemoglobin than oxygen, and so that means that if you've got carbon dioxide in the environment, it will preferentially go onto your haemoglobin. Carbon monoxide is found just in normal sort of pollution and tobacco smoke, so if you measure the levels of carboxyhemoglobin in people who smoke, it's significantly higher than other people. If you've got somebody who's poisoned with carbon monoxide, if you just keep giving them 21% oxygen, environmental oxygen, then the half-life to reduce the amount of carbon monoxide is 4 hours. So you're going to take a long time for your patient to get better. On the other hand, if you can get them into 100% oxygen, because the oxygen competes for the carbon dioxide reversibly, that half-life comes right down to 40 minutes. So much quicker. So, the key treatment for carbon dioxide poison is going to be oxygen at high concentration. You can obviously send them to a hyperbaric unit and try and give an even higher concentration of oxygen, but that only improves it from 40 minutes to 20 minutes. So, whether that would really make a difference, and given that you've got to get them there in the first place, I wouldn't have thought it would really.
And a brilliant question for the exam is, how does oxygen work in carbon monoxide poisoning? And then give you a list of possibilities. That's the sort of question we get, because that would test your understanding.
One thing that isn't on this sheet, which perhaps should be, is that in sickle cell disease, that the beta chain is abnormal, and they've got a valine instead of glutamate at position 6 in sickle cell disease, and that alters the formation of the haemoglobin, so its shape is different, and that means that it shifts the oxygen dissociation curve to the left, so it's less able to deliver oxygen to the tissues in sickle cell disease. The other thing that sort of upsets oxygen carriage is when the iron molecule in haemoglobin gets converted from its Fe2 form, which is what binds oxygen, to the Fe3 form. The Fe3 form of haemoglobin is methemoglobin. Have you heard of that? So that methemoglobin occurs at a natural sort of rate. Our own body produces nitric oxide, which converts the Fe2 to Fe3. But normally the energy processes within the cell, the glutathione that the cells make, can convert the Fe3 plus back to Fe2 plus. So there's a constant sort of process of forming methemoglobin and your red cell dealing with it and putting it back to the normal hemoglobin. But there are things like exogenous nitric oxide. The neonatal team do that, don't they? And procaine dapsone. So there are things that can cause methemoglobinemia. But fortunately, there is a enzyme within the erythrocytes. It's called erythrocyte NADH methemoglobin reductase, which deals with that. If you do have somebody who's got methemoglobinemia, then you can try treating them with vitamin C. Ascorbic acid helps, but the normal treatment is methylene blue. Methylene blue works by stimulating a different enzyme, NADPPH dehydrogenase, to reduce that Fe3. So methylene blue is one of your options for that. Of course, hemoglobin doesn't just carry oxygen. Hemoglobin also helps in the carriage of carbon dioxide in the blood. It turns out that there's a higher CO2 carrying capacity of hemoglobin at low partial pressure of oxygen. So it's exactly what you want. So in the tissues, as the hemoglobin is gradually losing its oxygen, it's developing a bigger and bigger ability to carry carbon dioxide. So venous blood carries more carbon dioxide than arterial blood. So that's great, because then presumably when it gets at the other end in the lungs, it can release the carbon dioxide into your lungs. And apparently that process accounts for about a third of CO2 carriage, the difference between the carrying capacity of carbon dioxide associated with hemoglobin. So that's the Haldane effect. I knew we'd get onto the embryology of hemoglobin production at some point. It turns out that in the first sort of 4 weeks, there's a primitive hemopoiesis process. And they call it primitive because it doesn't persist. The pluripotential cells, hematopoietic stem cells for that, die off. And so that the definitive hemoglobin production really starts from about 4 to 6 weeks. So it starts off in the yolk sac, and then the definitive one starts off in some other odd place called the aorto. Oh, I've forgotten now. I'm going to have to look it up. Where is it? Can you remember, Will?
No, I mean, it's not important.
It's not important.
The yolk sac is where it's coming from most of it, and then there's somewhere else.
It starts in the yolk sac, then it goes to this aorto place, and then eventually it ends up in the bone marrow. And in an infant, all of the bone marrow is involved in producing red cells. But later on, it narrows down to just proximal femur, proximal hema, and the central skeleton. So with the very, very early hematopoiesis or hemoglobin production, we're using some unusual globins. So this is where, is that epsilon or zeta? I'm not even sure. Yeah, that one's epsilon, this is zeta. Or this is the gamma chain and the zeta chain, forming unusual forms of hemoglobin. Then more and more hemoglobin F is made from 4 to 6 weeks onwards. And by the time you're born, I think the average amount of hemoglobin F is about 70 to 80%, because you've started producing adult type hemoglobin A, which is alpha 2, beta 2, from sort of around 30 weeks, something like that, 34 weeks. And we've made the point before that hemoglobin F has a higher association for oxygen than the adult hemoglobin A, and so you get this grabbing the oxygen off mum and then delivering it to the fetal tissues at a lower partial pressure of oxygen. So in a normal adult, you're getting sort of 95-97% alpha 2 beta 2. The hemoglobin F drops to very low amounts, usually about 1%. And there's this alpha-2 delta-2 haemoglobin, which is pretty ineffective at carrying oxygen, that persists around about 1.5 to 3.2%. And these ones all disappear. So thinking about some of the diseases that are affected by this, this girl here has got beta thalassemia disease. Whereas normally in an older child and adult, your hemopoiesis starts to be in the axial skeleton only, with the exception of your top of your femurs and humerus. In these children, they're busy making blood in their frontal skull, so they get this frontal bossing, and in the maxilla, because this child has got maxillary hypertrophy due to the extramedullary hemopoiesis there, or not extramedullary, due to medullary hemopoiesis, and then that causes this changes in the effect of the face. So you get the front teeth being shown even with the mouth closed. It's a sort of classic feature of appearance of children with thalassemia. They also get rather puffy eyes as well. I'm not sure what the process behind that is.
The medullary, the maxillary overgrowth blocks the sinuses.
Right, yes, of course.
So you can't get sinus drainage, so you get sinusitis as well.
Yeah.
When it's completely blocked off, that's the issue. And then things like the nasal line from dogs.
Yeah. So the hemoglobinopathy is about not being able to make, or thalassemias at least, are not being able to make your globin chains, and so there's really two ways it can go wrong. You can either not be able to make the globin chains, or you can make abnormal globin chains. So that's basically what we're going to be looking at in the next one. So beta thalassemia is when you're having difficulties making the beta chains. So this is the one that's produced on chromosome 11, and the sort of simple way to see it is that with beta thalassemia you've got two genes, one from your mum, one from your dad, and if one's working and the other isn't, it doesn't matter too much. You can still make quite a lot of your alpha-2, beta-2 hemoglobins, your normal hemoglobin A, and so you have a hemoglobin around about 80 to 100 grams per litre. You're generally pretty well, and it doesn't really affect your life very much. It perhaps gives you some protection against malaria, which is perhaps why it's so common. And that's the beta thalassemia trait. So the main problem is not to marry somebody who has also got beta thalassemia trait, because there's a 1 in 4 chance then that the two bad genes come together and a baby is born with thalassemia major, where they have two abnormal genes. With genetics, everything's incredibly complicated, isn't it? Because different mutations have different effects. So if you have two bad genes, but it's not too bad, then you can continue to make some working hemoglobin, and they have a sort of intermediate type expression of their illness. On the other hand, if you've got thalassemia mutations that mean you don't make any beta chains at all, then you're really in trouble. And so these babies will become anemic around about 3-4 months of age, when their hemoglobin F is dropping off, and they're going to need recurrent blood transfusions in order to maintain their hemoglobin at a decent amount. There's this idea of a sort of beta naught annotation for where your beta gene really doesn't work at all, or a beta sort of plus gene where it's not working perfectly, but it's working a bit better than a beta naught one. So that's broadly beta thalassemia. Alpha thalassemia is more complicated, because instead of just having one gene from your mum or one gene from your dad, there's actually two genes that control it. So you could get, so there's going to be 2 from your mum and 2 from your dad, which gives you 4 different possibilities for messing it up. Okay. Normal is to have all 4 alpha genes that are working perfectly well. So that's good. Asymptomatic carriers have 1 NAF gene. So say the mum has handed over a bad gene, alpha gene and a good one, and the dad's got 2 good ones, so that's not too bad. And then there's alpha thalassemia minor, which is where you've got 2 bad genes, or it could be the other way around. You could get from one person, or you could get 1 bad gene from one parent and 1 bad gene from the other parent coming together. Then you have really severe alpha thalassemia, where you've only got 1 working alpha gene, and so that's perhaps equivalent to your beta thalassemia major, only it's even worse. And they get this because this hemoglobin is unstable. It causes hemolysis, so it's not just the difficulty of producing the hemoglobin, but also it damages the red cells and causes hemolysis as well. So they're going to get splenomegaly alongside their microcytic anemia, whereas in the beta chain ones, that's much less of an issue. Unfortunately, if you've got all 4 NAF alpha genes, then it's incompatible with life, and the fetus will die in utero and of high drops. Does that make sense? It is a bit complicated, this, but we probably don't need to understand it in more detail than that, really.
One of the learning points is alpha thal minor has normal hemoglobin electrophoresis. So you've got normal amounts of all the other types of hemoglobin. So if you look and you try and do a hemoglobin electrophoresis, you won't pick up an alpha thal minor, whereas you will pick up a beta thal minor.
All right, I didn't know that.
And that to me was one of the things that I think is helpful when you've got data interpretation questions. You're saying, is it alpha or is it beta? Well, alpha thal minor has a relatively normal hemoglobin electrophoresis. There'll be maybe some subtle change there, but not enough that you'll be able to spot it in the data interpretation question.
So how do they make that diagnosis then?
That's a really good question, Stephen. I don't know.
It's really difficult.
So I think you need the family history and the genetics.
Yes,
To be
yes.
able to work it out.
Yeah. Interesting.
So if we had a case and we need to do 1 test, so there is no need to do hemoglobin electrophoresis.
Well, no, it is if you want to know if it's alpha thalassemia, but not if it's alpha thalassemia minor. But you wouldn't be trying to detect alpha. So if you've got a child with a mild microcytic anemia, and there's a family history of thalassemia, and they give you the hemoglobin electrophoresis, if it's normal, it's alpha thalassemia, not beta.
Yep.
You'll see I
Yep.
think you've got another one.
So
Yeah.
do the beta ones
Here we go. Here's the table.
survive because they haven't got 2 lots of genes?
Yeah. So here's the electrophoresis table, though, which I think is what you really want to get to, which is when you've got your data interpretation question, that's the table. If you've got foul trait, they'll have an excess of HbA2. But if you've got alpha trait, then they'll have a normal hemoglobin electrophoresis.
That, and the reason for that is that they're able to make enough alpha chains. They can make beta chains, so they can make alpha 2, beta
So
2.
when you've got 3 bad ones, you start to get into a spot bottom.
And it's only when you're going down to here that you really can't make them. Yeah.
Because it's biallelically expressed, I think is the phrase.
Yeah.
So
Yeah.
4 copies of the alpha.
So alpha thalassemia major is where you've got 3 copies, and you'll get all sorts of weird hemoglobins in there, which they'll be able to pick up in electrophoresis and diagnose. Beta thal trait is the one you see a lot of, and when you do electrophoresis, you'll just find that
You get a slight increase of HbA2.
is that
which-
correct? Shouldn't that be D2?
No, it's the HbA2. If we go back to the adult slide you had previously seen.
Beta thalassemia trait, they can make lots of HbA2.
Yeah, and so that's more than you would expect, I think, Stephen. If we go back to...
Yeah, you normally have. Where's the normal? Where's an adult?
That's what I say. Go back a few slides. We had it on there. Okay, so they usually only have...
Oh, A2. Yes, that's right. So I've forgotten that. So HbA is alpha 2, beta 2, and HbA2 is this alpha 2, delta 2. Yeah, good. So that fits with what I thought. That so this is that alpha 2, delta 2, which is a little bit more than 3.5%. So the normal haemoglobin is still nice and high. You've just got more of the rather weird alpha-2 delta-2 than you normally see. It's confusing, isn't it? Alpha-2, so haemoglobin A is the normal one.
Yeah, HbA is normal.
And HbA2 is that funny little thing that...
You've got some.
Yeah.
And it's how much? And it's 3.5% for thal tray, beta thal tray, and it's normal in alpha thal tray, or within the normal range.
Poor old beta thalassemia majors can't make the beta chains. So they'll get alpha-2 gamma-2, they'll get alpha-2 delta-2, and they'll get alpha-2 gamma-2, and they just can't make HbA because they can't make beta chains. But there are other children where they can make certain, or at least their beta chains kind of work a bit, and then it gets a bit more complicated. So those are the ones to try and ignore, really, because they're just very variable, because there's so many different genetic malformations of the beta gene that each one is slightly different from the other. And then moving on, so that is all about thalassemia. It's about actually making the globin chains. These ones are when the globin chains can be made, but there's something a bit wrong with them. And so hemoglobin S, we talked about that, valine and substituting for alanine at position 6. And so if you've got one good gene and one bad gene, then you'll have roughly 50-50 hemoglobin S and hemoglobin A. Slightly more of the good one, which is nice, isn't it? So it's slightly more difficult to make the bad one. Unfortunately, in sickle cell disease, you'll have almost all the bad hemoglobin and just a little bit of hemoglobin F to help make up difference. And hemoglobin C, less severe sort of sickle cell thing, but hemoglobin C is less severe. You can see that one. And this is where you've got one gene of hemoglobin S and from one parent, and one gene of hemoglobin C from the other parent coming together. So this is sort of bad news happening twice, but actually, so then you have quite a large amount of not good hemoglobin. And this is where you're sort of intervening with your hemoglobin S and beta thals as well, which gets even more complicated. Do they need to know in that detail?
Probably, actually. Yeah, probably. Certainly for AKP you would. So I'd say it's safe to know that, actually. I wouldn't put it in.
So that looks like a very complicated table that you're going to have to try and get your heads around.
But you can work it all out from first principles. I mean, you know if there's an HBS in there, it's sickle cell. If it's an HBC, it's HBC sickle cell disease. The only thing that's not in that table is alpha thal tray being protective in HB sickle cell disease. I don't know if you were going to go on to that.
No.
So alpha thal tray is good news when you've got sickle cell disease because it reduces the risk of polymerization. So there was a question from the front there. Do you want to ask it?
What's going to happen in the sickle cells when the hemoglobin F disappears?
Well, it persists, and it persists because it has to. You know, so necessity is the mother of invention, and in fact, you can increase the amount of persistence by giving certain drugs. So there's more of that, but we'll go on to it maybe afterwards, and we'll pick up on that. So some of the treatments that we use for sickle cell disease increase the production of HbF deliberately.
So they keep that throughout their lives?
Yeah, well, we all have a little, but sickle cell have more. So you've still got some hemoglobin F in there, just not a lot.
So sickle cell disease, we're almost finished, by the way, poor things. This is that protective effect that Will was talking about. Why was the protective effect occurring?
So the protective effect of hemoglobin F is that, well, it's not got any beta chains in it.
Right, I see. So it's just,
of course you don't
yes.
sickle that
Yes.
hemoglobin.
Yeah.
And sickling occurs as a result of the intracellular concentration of HbS. So HbS has a tendency to polymerize.
Turning into these
It
things.
joins up, becomes sticky, and sticks together. You know what polymers are, yeah? So if it's soluble hemoglobin, it's okay. But when it polymerizes, it becomes stiff and sticky and makes the cell deform and then die. Okay, so it kills cells because they then can't bend in the spleen and they get destroyed. That's what happens in sickle cell disease. It's a bad thing. The tendency to sickle is related to the 34th power of the concentration of hemoglobin S within the red cell. So very small changes in the concentration of hemoglobin S make a very big difference to the tendency to polymerize, which makes a very big difference to the number of sickle cells you've got. And that's very interesting. So it's a very small change in the amount of hydration inside the red blood cell. So the amount of water in there will make a big difference. Very small concentrations in oxygen will tend to promote polymerization. So when it's oxygenated, hemoglobin is less likely to polymerize than when it's deoxygenated. So if you get into a situation where a child is hypoxic and dehydrated because they're poorly, because they've got a virus affecting their upper respiratory tract, if they've got sickle cell disease, they go into crisis. And the treatment is hydration and oxygen. So now you know why. It's all based on the science. Actually, the inheritance of alpha thalassemia trait reduces HbS concentration as well in the cell. It makes them mildly anemic, but it helps because in this situation, anything that lowers HbS concentration intracellularly reduces the tendency to sickle, so you have less severe disease. So it's all in the science. And then the electrophoresis, which is probably the slide I'd have ended with, all makes sense because you can pull it all together and go, wow, that's really helpful. I can see why we see the changes now. Okay. So the cause of sickle cell, there's an example in the chapter of clinical cases that goes through all of that in a little bit more detail if you want to read in more detail. And as I say, it's worth a read. Amusingly, it's the only thing I've ever co-authored with my wife.
Brilliant job. So I think that covers that nicely. I'm just going to go on to hemolysis, and then we've done. So we've talked about how hemolysis occurs with cells that are old and have lost their ability to maintain their shape because their energy systems is running out, or because if there's disease disorders like spherocytosis, elliptocytosis, where the cytoskeleton isn't working well. Or the enzymes within it aren't working well, G6PD, pyruvate kinase not working well, or if there's hemoglobin that tends to polymerize and precipitate and damage the cells. And in particularly in alpha thalassemias, the hemoglobin itself is unstable and again can sort of precipitate. So those are your inherited things. And acquired causes of hemolysis, you know about autoimmune. We've thought about how in hemoglobin syndrome the verocytotoxin damages the surface of red cells and the endothelium and causes hemolysis. Obviously, there's infections and poison. So there's lots of things that cause hemolysis. So you get hemoglobin. In these inherited ones, often the red cells are removed within the spleen and within the liver, and so hemoglobin doesn't get released into the blood. But if blood does get released into the blood, where you've got sort of severe hemolysis occurring in blood vessels, then that's when you're going to get your low haptoglobins, high methemalbumin. Obviously, if you've got hemolysis, you're going to get anemia, and that leads to more erythropoietin production, and therefore more production of red cells. And so you end up with an increased proportion of young red cells in the bloodstream. So when G6P deficiency, they have a high retic count, as we were saying, about sort of 8-10%. And obviously, as you're breaking down the red stuff, it turns into the yellow stuff. So you're going to get an increased bilirubin in there. So I'm sure that's clear. So if this nasty process of hemolysis occurs within blood vessels, then you're going to get the contents of red cells actually released into the blood. So that's where you get your LDH going up, and your haptoglobin going down, and you can actually see damaged red cells if you look at it under a microscope. I don't think people test it for very much. Methemalbumin is another thing that goes up. That's albumin carrying hemoglobin that's been oxidized. So those are the sort of features of hemolysis. Right, so there's a lot there, isn't there? Sorry, I've gone on too long. But hopefully the discussion has been worthwhile. And it is sort of one of the things I perhaps didn't say at the start is it's a difficult area, and I think it's been poorly taught in medical school. Probably because when I tried to do the reading for this, I find myself reading at least 4 different chapters and then finding I hadn't covered it. There were other articles in other places, so everything's spread about rather than brought together in one place. And yet this is something that you say is tested frequently, so is worth finding out about.